Evening, all the aspirants present here. Today's topic is gastroenterology, and the faculty that we have here is Dr. Nilanchal Chakrobarty, sir. He is a consultant critical care at Apollo Multispeciality Hospital, Kolkata. Over to you, sir. Thank
Yeah,
you.
thank you for the kind introduction. First of all, gastroenterology is a huge subject, and covering the whole topic in a class may not be possible. I'll try to highlight on some important topics which may be necessary really to need to go through all the questions one by one so that the doubts are cleared. So it's a question answer based session, and I'll share the slides because some of the slides are really busy. So I'll share the slides and I'll ask all the examinees to go through the topics thoroughly. So first of all, first question is regarding the diagnosis of chronic pancreatitis. So it'll come like this. The 50-year-old gentleman comes to the clinic for a review with chronic diarrhea and accompanied by intermittent abdominal pain, and his finding is impossible to maintain his weight. So he's losing weight. It's a chronic problem and diarrhea. So indigestion and malnutrition is an issue. There's a history of alcohol intake and smoking, and they will be given some blood reports which shows that low hemoglobin, normal WBC count, and lowish sodium and lowish albumin. So it's a chronically malnourished patient with history of alcoholism and abdominal pain coming to clinic. So the question is very straightforward. If you suspect chronic pancreatitis, what is the best test to diagnose? The answer is fecal elastase, which is usually secreted from there, and it is in low because it's chronic pancreatic insufficiency. The exocrine function of the pancreas being drained. None of the other tests like amylase lipase is for chronic pancreatitis, it's for acute pancreatitis. And also the fecal fat estimation can be varied with diet. So the answer is the elastase. Next is very important topic, that is a different kind of jaundice in pregnancy. So the question will come like a 32-year-old lady coming to the outpatient clinic with the yellow color discoloration of the eye. So jaundice is strictly there. The pregnancy weeks is 36 weeks with her first child, and she feels well in herself and has no relevant past history other than some transient episode of jaundice in her late teens, and takes no medication. So if you go by the examinations, you can see the clinical examination reveals some icteric sclera and excoriations over the arm. So some itching and jaundice, both are there, pruritus and jaundice. So if you go by the lab value, you can see the bilirubin is quite high along with the alkaline phosphatase, which is quite high, so which means there is some amount of cholestasis. And urine shows bilirubin, which means that conjugated hyperbilirubinemia is there. Other than that, there is no signs of thrombocytopenia or hemolysis. So the diagnosis here is cholestasis in pregnancy because direct hyperbilirubinemia along with pruritus is the clinical symptom. So cholestasis in pregnancy is by far the most likely diagnosis because condition is usually caused by the bile acid transporter defect, and usually happens in late pregnancy, but it is sometimes it is harmful. It is not associated significant constitutive symptoms like vomiting and all. So patient is relatively well clinically, but have presenting with jaundice and pruritus, and no other features of thrombocytopenia, coagulopathy, hypertension, and all other systemic symptoms are there. So toxemic symptoms are not there. This is a very milder disease like cholestasis. Next, the causes of recurrent gastric and duodenal ulceration. A 35-year-old gentleman is being investigated for recurrent gastric and duodenal ulceration. So, recurrent multiple ulcerations are happening, which has been diagnosed with endoscopy. He has suffered from different bouts of abdominal pain, so recurrent problem with intermittent diarrhea, although his weight is stable. So it's not that malignant disease, is a benign disease because the weight is stable. On examination, the abdomen is soft, so and no organomegaly. So there has to be some amount of hormone secretion which is causing multiple ulcers. So if you go by the lab value, you can see the hemoglobin is in the lower side. Uh, so lower side and sorry, just a moment. Yes. Yes. So the options is like omeprazole therapy, pernicious anemia, gastrinoma, H. pylori infection, carcinoma of the stomach. So answer is of course gastrinoma. It is because all of the above conditions associated with hypergastrinemia, which can cause multiple ulcers. But gastrinoma is the correct answer because the diagnosis patient with gastrin level of more than 1,000. So fasting gastrin level is quite high; it should be low, and the basal output more than 15 millicurie. Here it is the fasting gastrin level is around 200 and post secreting gastrin is 500, which is quite high. So the answer is gastrinoma. Next, again, patient, 36-year-old patient, coming with 3 months history of diarrhea and symptoms are increased stool frequency, particularly in the mornings, bloating and vague abdominal pain. So malabsorption is there. Stool is soft and no blood. So no melena is there. Hemodynamically, patient is stable with 110/70 blood pressure with no tachycardia, and the body mass index in 22 is not that low. But if you see the lab values, the hemoglobin is low, the MCV is in the higher side, so there is vitamin deficiency, and so and also if you options are like anti-tissue transglutaminase antibodies or endomycin antibodies or colonoscopy or upper GI endoscopy. So actually any patient who comes up with low hemoglobin, the first investigations are basically to go for endoscopy at duodenal biopsy to rule out any this celiac disease and other causes of diarrhea from the duodenal biopsies. So, sometimes the patient may present with a history of weight loss and other joint pains also. So, here comes the second history, which is 44-year-old gentleman with 10-month history of pain in his lower back, hips, ankles, and feet. He has tried osteopathy, acupuncture, and diclofenac. So, pain is very severe. It's not coming to relief with usual medications. And of course, because the malabsorption, the patient is very much tired. So if you go by the lab value, the hemoglobin is quite low. It is 71, and sodium is in the lower side. Albumin is the lower side. So there is significant malabsorption history. And he had no history of dysphagia or night sweats, which usually comes with malignant disease or different kind of lymphomas. A past history includes hypothyroidism, for which there is some amount of autoimmune disease histories maybe there associated. On examination, his clothes feel loosely and looks pale, so he's losing weight. He has no clubbing or lymphadenopathy, which rules out any kind of malignancy. He had normal cardiac, chest, and abdominal examinations. On joint examination, there is pain, moving joint, and no obvious focus of the pain. Chest X-ray is normal. Fecal immunochemical test is negative. So if the options are like Crohn's disease, celiac disease, sickle carcinoma, Whipple's disease, which is also a multisystem disease, and intestinal lymphangiectasis, the obvious reason is in this patient is celiac disease because celiac disease is quite common. It is 1 in 100 to 1 in 30, and only one-third of the patients with chronic diarrhea and steatorrhea may have malabsorption issues. Iron deficiency and protein losing enteropathy will be there because of the celiac disease, and it can be differentiated from Crohn's disease by, of course, biopsy. And carcinoma and other lymphangiectasis are associated with lymphadenopathy. So that is out of the question.